Hello everyone, I am myself Dr. 𝗓𝐼𝐻𝐫𝐢𝐚. I am the general medicine educator. So in this session, I'll be doing the quick discussion on the multiple choice questions on the topic of the sarcoidosis. So the first question is, which of the following is seen in sarcoidosis? Hypercalcemia, hypocalcemia, hyperphosphatemia, and then the hypophosphatemia. So the answer is the hypercalcemia. And why there is a hypercalcemia? That is because the non-caseating granuloma which is present or which are formed in case of the sarcoidosis, they produce excess amount of vitamin D, and this vitamin D will increase the calcium absorption across the intestine, causing the hypercalcemia. So the answer is A. Next question. The patient with breathlessness and the skin lesions, what is the diagnosis? The options are sarcoidosis, phacomatosis, pulmonary lymphangiomatosis, Dressler syndrome. The answer in this question is the sarcoidosis. So you need to know the cutaneous variant of the sarcoidosis, right? So whatever you are observing here, these are the cutaneous lesions that you observe in sarcoidosis. And one more important point which is telling you that it is sarcoidosis is the presence of bilateral hilar lymphadenopathy along with the cutaneous manifestations, and these patients presenting with breathlessness and skin lesions, very much suggestive of the sarcoidosis. All right, next question. Sarcoidosis is characterized by all except cavity formation, panda sign, hilar lymphadenopathy, eggshell calcification. So panda sign is seen. So panda sign of sarcoidosis, right? You see that in case of the gallium-67 uptake studies, right? And this panda sign is due to increased gallium-67 uptake within the lacrimal glands and as well as the parotid glands. And you also have lambda sign in the gallium-67 uptake studies, and this lambda sign in patients with sarcoidosis, that is mainly because of increased gallium-67 uptake in the bilateral hilar lymph nodes and as well as right paratracheal lymph node. Then yes, hilar lymphadenopathy will be there. That is one of the hallmark feature of the sarcoidosis. And the eggshell calcification. Eggshell calcification, it refers to the fine, right? It refers to the fine calcification seen in the periphery of a mass, right? And it usually relates to the lymph node calcification. So what is that eggshell calcification? That is bilateral hilar lymph node calcification. The shell-like calcification, it is up to 2 mm thick, right? The shell-like calcification, it is up to 2 mm thick, and that must be present in the peripheral zone of at least the 2 lymph nodes, right? Then in sarcoidosis, the calcification is uncommon but not mentioned as rare. It is uncommon. And you take this cavity formation. Cavity formation is rare in patients with the sarcoidosis. So all except the answer is sarcoidosis. All right. Next question. Arthritis common with uveitis seen in rheumatoid arthritis, ankylosing spondylitis, Still's disease, Rheumatoid disease, right? So this is actually the question of the ankylosing spondylitis. So these patients with ankylosing spondylitis, they develop anterior uveitis, and along with that there is arthritis. So what will be the form of arthritis? That will be the sacroiliitis, right? That will be in the form of the sacroiliitis. And along with the sacroiliitis, there will be also involvement of the spine. And the spine involvement, it starts from the lower part of the spine. That is from the sacrum, then lumbar, then thoracic, and then the cervical area. So that will be the spine involvement. So along with uveitis, the arthritis present is suggestive of the ankylosing spondylitis. And ankylosing spondylitis, as we are very much aware of, these are the one where you have the 𝐻LA-B27 predisposition or 𝐻LA-B27 is positive. All right. Then you take immune mediated causes of the uveitis. So immune mediated causes of the uveitis, you have multiple conditions where you have immune mediated uveitis. One among that is the ankylosing spondylitis. The other one is the Behçet's disease, right, where you have the presence of the recurrent oral ulcers. Then the inflammatory bowel disease, you can have this uveitis. You also see that in patients with multiple sclerosis. Then reactive arthritis, followed by that in cases of the psoriatic arthritis, rheumatic fever, then sarcoidosis, next in cases of systemic lupus erythematosus, then in case of primary sclerosing cholangitis. So these are the conditions where you have the immune mediated causes of the uveitis. All right, the next question. The most common cause of sudden death in sarcoidosis is pneumonia, cor pulmonale, arrhythmias, liver failure. So please remember, it is your arrhythmias, cardiac involvement in the form of the non-caseating granuloma that will cause the scar formation within the heart. And this particular scar is what is responsible for the arrhythmias causing sudden cardiac death, right? And this initial inflammation can trigger which arrhythmias? Ventricular arrhythmias. And the type of arrhythmia which is very common in patients with sarcoidosis will be monomorphic, right? That will be in the form of monomorphic ventricular tachycardia, right? That is the most common cause of death. And the other causes of death would be the respiratory failure, then angioinvasive mycetoma. So these are the other causes of sudden cardiac death, okay, or other causes of death in patients with sarcoidosis. But the most common cause of sudden cardiac death in sarcoidosis will be arrhythmias. All right, next question. True about sarcoidosis. Causes large cavitary lesions. Spontaneous remissions may occur. Tuberculin test is negative. Caseation and necrosis may occur. So the true statement is the spontaneous remission may occur. See, the acute sarcoidosis, it is more common in whites than compared to that of blacks, and that is usually associated with the spontaneous remission. And the spontaneous remission also occurs in patients with Lofgren syndrome. Spontaneous remission can also occur with bilateral hilar lymphadenopathy, ankle arthritis, and then the erythema nodosum. Okay, then you take this causing large cavitary lesion. It is an incorrect statement. The tuberculin test can be positive in patients with the sarcoidosis, and it is not caseating necrosis, it is non-caseating necrosis that you come across in patients with the sarcoidosis. All right, next question. Most common cause of the unilateral hilar lymphadenopathy. The options are histoplasmosis, sarcoidosis, aspergillosis, and then tuberculosis. The most common cause of the unilateral hilar lymphadenopathy, that will be the tuberculosis. Whereas in sarcoidosis, we have discussed it as bilateral hilar lymphadenopathy. Okay, next question. Sarcoidosis is least likely to be associated with uveitis, pericardial effusion, erythema nodosum, lymphadenopathy. So, lymphadenopathy, it is the hallmark in case of sarcoidosis, right? And then lung involvement, it is seen in almost 90% of patients with the sarcoidosis. Followed by the lung involvement, it is the skin involvement in the form of lupus pernio and as well as the erythema nodosum. Then uveitis is also very common. That is your anterior uveitis and as well as pars planitis. But the pericardial effusion in patients with sarcoidosis, right? So this is one of the rare manifestation in patients with the sarcoidosis. Pericardial effusion is not common, right? And the cutaneous symptoms already we have discussed, that is erythema nodosum and as well as the lupus pernio. Next question. Following cranial nerve is involved in patients with sarcoidosis. The options are first, second, third, fourth. So once you get this particular question of sarcoidosis and the cranial nerve, your eye will be searching for the seventh cranial nerve, right? And that too, it is bilateral seventh nerve involvement in sarcoidosis, and that will result in what is called as the facial diplegia, right? That will result in facial diplegia, all right? But the next to the seventh cranial nerve involvement, the next most common nerve will be the second cranial nerve, and that will result in the optic neuritis, right? That will result in the optic neuritis. And what are the other central nervous system involvement features? The other central nervous system features will be in the form of the lymphocytic meningitis, will be in the form of central diabetes insipidus, can also cause the myelopathy, can also cause the seizures, and the cranial nerve involvement most common seventh and followed by that second. And second cranial nerve involvement is in the form of the optic neuritis, right? Next question. The primary involvement of which organ is so far not reported to be affected by the sarcoidosis? The options are heart, adrenals, then kidney and brain. So the primary involvement of the adrenals is not seen in sarcoidosis, okay? So the adrenal involvement in sarcoidosis, it is rare or absent. As such, you don't have the primary involvement. The non-caseating granuloma will not go and accumulate within the adrenals, causing adrenal insufficiency. But this non-caseating granuloma it accumulates in the pituitary, so thereby causing pituitary insufficiency. And what will happen to the ACTH levels? ACTH levels will be reduced, and once the ACTH levels are reduced, that will cause secondary adrenocortical insufficiency but not primary adrenocortical insufficiency. Cardiac involvement will be there, that will be in the form of the restrictive cardiomyopathy and as well as the cor pulmonale. And because of this restrictive cardiomyopathy, they can develop arrhythmias causing sudden cardiac death. And kidney involvement can be there, that is in the form of the renal hypercalcemia. And brain involvement can be there, that is in the form of the seizures, that can be in the form of the central diabetes insipidus, that can be in the form of lymphocytic meningitis, seventh cranial nerve involvement, and then second cranial nerve involvement. That will be your brain involvement in patients with the sarcoidosis. But among all the organs, the one most important is lung, followed by that skin, followed by that the eye involvement, followed by that liver involvement, and then cardiac involvement. So if you see the next question, tufting of the distal phalanx is characteristic feature of psoriatic arthropathy, sarcoidosis, hyperparathyroidism, and then hypoparathyroidism. So tufting of the distal phalanx is the characteristic feature of the hyperparathyroidism, right? The tufting of the terminal phalanges is observed in case of the hyperparathyroidism, is observed in cases of the acromegaly, and it is also observed in cases of the gigantism. Okay, so these are the conditions where you have the tufting of the terminal phalanges. All right, next question. All of the following are the features of sarcoidosis, except. The options are right paratracheal lymphadenopathy, cardiomyopathy, hypercalcemia, malabsorption syndrome. So the one which you don't see is malabsorption syndrome in patients with the sarcoidosis. Right paratracheal lymphadenopathy, yes, that is a part of your Garland's sign, which is also called 1, 2, 3 sign, which is also called the pawnbroker sign in patients with the sarcoidosis. All right. And cardiomyopathy, yes, there can be development of the restrictive cardiomyopathy. And hypercalcemia, that is because of the vitamin D production by the non-caseating granuloma, right? And not only this restrictive cardiomyopathy, the sarcoidosis can also cause the dilated cardiomyopathy, but predominantly it is your restrictive cardiomyopathy, right? Next question. Hereford syndrome consists of fever, parotid enlargement, and facial palsy, and arthralgia, bilateral hilar lymphadenopathy, erythema nodosum, and anterior uveitis. So remember, in Hereford's, you don't have this bilateral hilar lymphadenopathy. What is very important along with the fever, parotid enlargement, facial palsy is the anterior uveitis, right? So what is another name for this, the Hereford syndrome? The Hereford syndrome, it is also known as the uveo-parotid fever. Right, it is also known as the uveo-parotid fever, and this is the variant of the sarcoidosis. Right, this is the variant of sarcoidosis, and this comprises of like fever, parotid enlargement, facial palsy, and then ocular involvement in the form of the anterior uveitis. All right, next question. True statement about the sarcoidosis is serum amyloid A is used as the marker for sarcoidosis. 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 test is diagnostic. Hypocalcemia, pleural effusion is common. See, the true statement in sarcoidosis is the serum amyloid A is elevated, and it is a marker of, right, and it is a marker of granulomatous inflammation. Right, it is a marker of granulomatous inflammation seen in sarcoidosis, right? And if you take the 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 test, it is used previously, but it is not definitely diagnostic, and it is no more used in these days, right? And hypocalcemia will not be there, the hypercalcemia will be there. And the pleural effusion, that will be exudative type of pleural effusion that can occur, but that is seen rarely, around in 5% of patients, and the pleural effusion is not common. So the true statement is the serum amyloid A is used as the marker of the sarcoidosis. All right, next. Lupus pernio is a complication of sarcoidosis, skin tuberculosis, SLE complication, discoid lupus erythematosus. Lupus pernio is a complication of the sarcoidosis, right? So this is one of the most common cutaneous manifestation in patients with sarcoidosis. The lesion is typically described as red to purple in color, right? It is red to purple in color. And why is it purple in color? That is because of increased vasculature, right? That is because of increased vasculature. And where will be the distribution of these particular rash, right? So basically it is like swollen rash, and this swollen rash, it is present or distributed over the nose, distributed over the cheeks, lips, or the ears. These are the places where you have the lupus pernio, and it is particularly resistant to both surgical and medical therapy. Okay, so this lupus pernio, it does not respond to either medical management or the surgical management. So that is about the lupus pernio. All right, next question. Garland sign on the chest X-ray in sarcoidosis involves all except. right paratracheal lymph node, right hilar lymph node, left hilar lymph node, left paratracheal lymph node. So you take this Garland sign. What is another name for this particular Garland sign is, it is also called 1, 2, 3 sign, right? And it is also called as the pawnbroker sign, right? Also called as the pawnbroker sign, okay? Where there is involvement of your right and left hilar lymph node and right paratracheal lymph node. But left paratracheal lymph node involvement is not observed in patients with the sarcoidosis. All right, next question. In rheumatoid arthritis, the pathology starts in articular cartilage, capsule, synovium, muscle. Please remember, it is in the synovium. And what will be that synovial involvement in rheumatoid arthritis? That will be in the form of synovial cell hyperplasia, right? And endothelial cell activation. Right? Endothelial cell activation. So these are the two things that will cause the inflammation of the synovium, causing synovitis. Followed by that synovitis, you have the involvement of the cartilage and as well as the bone. So that is about the synovium involvement in rheumatoid arthritis. All right. Next question. Bilateral parotid gland enlargement is seen in all of the following conditions except sarcoidosis, SLE, chronic pancreatitis, Sjögren's syndrome. So in SLE, you don't have the parotid gland enlargement, whereas in sarcoidosis, chronic pancreatitis, and as well as Sjögren's, you have bilateral parotid enlargement. And that bilateral parotid enlargement in patients with sarcoidosis, that is called as uveitis, okay, or it's also called as the Hereford syndrome. All right, so that is about your condition where the parotid gland enlargement is not observed. Next question. The following cranial nerve is most commonly involved in patients with sarcoidosis: 2, 3, 7, 9. So that will be your 7. Okay, and that will be in the form of bilateral, and that we call it as the facial diplegia. Right, facial diplegia. Okay, so these are some of the questions in the topic of the sarcoidosis. Thank you very much.